lot of stuff in the news lately. Like I sent you that email, like I'm gonna
Mhm.
do my best.
That's all we can do, right?
Yeah, it's all right. See what's going on
Very
behind me here.
spring.
Yeah, I'm just trying to not be a commercial. Well, hold on a second. Okay. I guess that's some other famous thing. Um, yeah, there's just been so much going on in the news, in multiple places too. So I'm gonna just provide the facts, provide the information, and just, we'll go from there and see.
All right, sounds good.
Yeah. Obviously you can hear and see me, so that's good.
Yep, everything looks good on my end.
Okay. And
Mhm.
I am going to share and get myself just ready to do my thing.
Sounds good.
You could see that.
Yep, you're
Okay,
good.
great.
Mhm.
Thank you.
No problem. For those of you just joining us, good evening. We're gonna get started in just a few minutes. We're just letting some folks jump on, get situated, and then we'll get started.
Hey everyone, we're just gonna get started in like maybe one more minute or so. Just got a lot to get to, but I also want to give everyone a chance to get here if they're trying. What do you think, Satori? Time to go?
Yep, whenever
Yeah.
you're ready, feel free to take
Okay.
it away.
Yeah. All right. So, hi everybody. My name is Jason Reckman. If you were here, I think it was last week. We started this series and started off talking about general disabilities. And tonight we're gonna a very timely talk about autism spectrum disorder. We're gonna talk about some hidden disabilities in there as well, which we talked about last week as well, but we'll get into a little bit more detail. And moving forward, we'll be able to, later in tonight's presentation, we'll actually see um, some stuff that's around the country and specifically in your backyard um, for autism and things that are related to that. So hopefully you'll enjoy it. There's also been a lot going on in the news lately surrounding autism for some very high level front and center stuff and some other things also involving first responders. So hopefully we'll be able to talk about that a little bit as well. So thank you for joining. I know it's a Monday evening, holiday day after holiday for a lot of folks. So I know that a lot of folks might even be away still or whatever it is they're doing. So thank you for joining for what it's worth. Again, I always want to like acknowledge Satori for answering the call, so to speak, and Sonia for all your help lately. Been really, really helpful with putting things together and making sure we keep moving forward. So again, I'm Strategic Development Director for Perform Care and Amara Health. Really just trying to make the community a safer place for people with developmental disabilities and trying to bring awareness, acceptance, and everything in between when it comes to that subject matter. So um, moving right into things. When we talk about autism spectrum disorder specifically, you'll see in the world around us, there is so much symbology and specific language that we're told that we're supposed to use, or we're told that we're not supposed to use, depending on the message behind it and the intention of that messaging behind it. So I just want you to kind of keep that thought in your head. We're going to come back to the symbols and such, but I just wanted to introduce the idea. You'll see here at the bottom there's a quote unquote celebration of autism awareness. And there's a specific call out here for International Autism Awareness Day. Even since the last time I've updated these slides, the language has already shifted forward. And I know we're recording this. So if anybody's seeing this, today is April 21st, 2025. If anybody's seeing this, like probably even by the summer, some of what I'm talking about may have already become antiquated. Um, Autism spectrum disorder is a very fast moving concept because we have both the scientific aspects of it and we have the social aspects of it. And there's a lot of social going on and influencing policy and other things that on one side might be a good thing to have autism be the front and center for something which usually does not happen, especially at the highest levels of our government. But on the same side, we're potentially disrupting things that have been going on for a very long time, how we look at things, and how people have accepted a diagnosis. So again, just kind of the prelude to everything, there is a lot of movement when it comes to things, a lot of progression. And if you have any background in autism, you've probably noticed it yourself, especially if you're working in the field or have somebody or have the diagnosis yourself. So let's just get the toughest part out of the way, right? Let's do the diagnosis first. Where does it come from? How do we get there? So what you have here between this slide and the following slide, which is here, you have a trimmed down version of what we would find in the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders. Autism spectrum disorder got its newer name, which is Autism Spectrum Disorder, around 2013 when the newest version of that DSM book came out. And that book is the physician's desk reference. It's the ICD, which is the International Code of Diagnostic Symptomology. Um, the reason why it's so important is because when we changed the diagnosis, it changed who was included in that diagnosis. So that's an important thing to remember. It was not a spectrum disorder previously to 2013 when the DSM-5 came out. And this really changed a lot of things. And it's starting to really show that as we progress into the middle of this decade. And I'm saying specifically, this is a trimmed down version. If you were very interested in this and you want to look, there are paragraphs between each of these numbers. Here's my camera. Paragraphs between each of these numbers that provide even more detail. But this is right out of there. I'm paraphrasing a little bit, but nonetheless. A being the top part of the classification. So you'll see that there's A, there's a B, and then you can see C, D, and E are a lot smaller. So just keeping that in mind, you have to have something from each of these to meet the criteria for clinical diagnosis. So what are those clinical criteria? Across multiple contexts manifested by following currently or by history. This is an important word here, by history. So you have to have at least one of these three things. Deficits in emotional reciprocity. So, and then it provides exactly what that is, ranging from abnormal social approaches and failure of back and forth conversation to reducing shared interest and emotion. So what does this all mean? When you talk about the abnormal social approach or failure of that back and forth conversation, this would be somebody that if you're just meeting them for the first time, which would be very likely in your scenario of working as a deployed MRC volunteer, this is important to recognize and understand right off the bat. If you approach somebody and ask them what their name is, there's a good chance they will answer that question in a way that may perk your ears up a little bit, where their response to you may not be exactly the same. So for example, if I were to approach somebody quietly and ask them, can I have your name? The response might be at not a loud volume, but not a matching volume, if that makes any sense. Not in a conversational back and forth where it would meet the norms of what you might be used to as somebody that may not have an autism spectrum disorder diagnosis. So being able to maintain a back and forth conversation. There's a friend of mine. I have been friends with him for 20 plus years. He is someone that is one of my closest friends. He's a very, very involved person in the community. He's a teacher. He is a family man. He is somebody that you may not expect to have this diagnosis on paper when you would like talk to him. If you were to see what he does, on paper, so to speak. And then when you talk to him, you immediately get a sense of the conversation is a little bit different from what you might be used to. So for example, a lot of the conversations that we have at first are very civil, I guess I would say, you following like the civil discourse of a conversation. Hi, how are you? Great, how are you? How's the family? How's your job? Going through those normal things that you've been taught through your socialization over your lifetime on how to do that. I've been friends with him again for decades. And after that first couple of minutes, he continues to still struggle, even with me, being a licensed therapist, somebody that knows this population very well. He struggles to get to the next step of continuing conversation or going anywhere into a new area that we haven't talked about heavily in the past. He likes to specifically go back to remember when, like when we were talking about things in the past, things that are comfortable for him, because once we go into anywhere that's beyond that, things to get a little bit shaky. There might be large pauses in his speech. There might be, it says here, reduced interest or emotion. So I might tell them, hey, I just did this really great training with the Philly MRC, and his response might be very flat. Again, that's what emotional reciprocity is, back and forth. And you can notice that, I don't want to say the word easily, depending on the person's level of functioning, But for the diagnosis, it has to be a marked deficit. So this is becoming an issue in someone's social, their occupational, their family relationships. And again, it doesn't have to be this thing. It could be something else. But nonetheless, there is some issue with socialization and patterns of social interactions. May not know how to initiate a social interaction very well. It could be that he's full of anxiety, or it could be that he simply does not have the ability to initiate those social interactions because he simply doesn't have the confidence, because there's not a lot of history of him doing that successfully. Moving into nonverbal communication, for you as an MRC volunteer in a deployed situation, nonverbal communication is what you're going to more than likely get the most information from, especially obviously from somebody that cannot communicate verbally. And even with folks that do communicate verbally, nonverbal communication is something that is extremely important to understand what those ranges of emotions may actually be. So here it says ranging from poor integrated verbal and nonverbal communications to abnormalities in eye contact and body language. So I'll give you a pretty concrete example of verbal and nonverbal communication. I had worked with a client once who just simply did not understand nonverbal communication, that standing very close to a man and staring at them in the face could, in a public situation, could provoke somebody aggressively. And this was something that we had to work on, because he just would stare at folks, and we would be out in public, and sometimes people would give a look back, and then it would be a staring contest. And I'm sure, Philadelphia, if you go and try to do that on a street corner, it may not work out well for you. Do it at an Eagles game, all the same kind of thing, right? But you understand there are situations where you should and shouldn't do that. And culturally, at least I would say in the Northeast, nonverbal communication, when you're staring at somebody that you don't know, usually you're looking to engage with them for some reason. You're not just looking to observe them, which is a lot of the cases here. Facial expressions, I mentioned it just now about having a flat face or a flat affect. That is something that is pretty common when we're talking about that nonverbal communicative behavior. A flat affect may also go back up to this emotional reciprocity, not being back and forth. If there's somebody that's grieving, or somebody that's having a tough time, the person with the diagnosis of autism, or ASD, as I'll call it, does not necessarily have that ability to show empathy, to show sympathy. So keeping in mind those types of things. So the body language is the same thing. Legs crossing, arms crossing, they may not mean the same things. Usually as a therapist, if somebody's sitting in front of me with their arms crossed like this, that tells me that they're guarded. And that might be a good assumption in a lot of situations. But again, back to the MRC situation, and you've got somebody with autism out of their normal living situation, doing this could actually be something where they're self-soothing, where they're giving themselves pressure for a reason that I'm going to get to on the next page. So don't just make assumptions, but that this is the same thing for everybody is I suppose the point of that. And before I actually go any further, one thing to also say is, just looking at a person, you cannot tell. There's not a look that person has the diagnosis of autism. Next time we meet, we're going to talk about Down syndrome, and there is a physical look to it. It's a genetic thing. We know it is. But with autism, there isn't that. So again, it's hard to identify in certain situations, which is why we're discussing that here. Developing, maintaining, and understanding relationships. Again, there could be struggle to understand social contexts, understanding when things are certain, when certain behaviors are appropriate and when they're not, who it's okay to joke around with in your home versus in public, and understanding that type of back and forth of who is somebody of authority that you have to listen to versus somebody that isn't. So for example, maybe not necessarily understanding that somebody with a diagnosis in a social context should be listening to the commands from a police officer, or from a firefighter, or an EMT, or in this case, an MRC volunteer, or a health department person. There are lots of different avenues can go down, no matter what the level of functioning is, quote unquote, that can be problematic down the line. The next, chunk, so to speak, for this is restricted patterns or repetitive patterns of behavior. So you may have heard people that have the autism diagnosis may have very, very strict interests in certain things, like taking model cars, putting them together, taking them apart, understanding computers, doing certain repetitive motor movements. These are all symptoms of this portion of autism spectrum disorder. By having these really restricted, fixated interests that are abnormal in intensity. So it's beyond somebody being a really big sports fan. This is life to this person. It is something that they can't get away from. And a lot of times it is used as a reward system, and sometimes that reward system is very helpful, and sometimes it becomes difficult. And I'll cross that bridge shortly. One of the other things that's extremely important, especially for MRC folks, is understanding sensory input and why that becomes problematic or important to know for somebody that's supporting others with autism spectrum disorder. There might be hyper or hypoactivity for sensory input. So what does that mean? Somebody with this diagnosis might become very distracted or unfocused or agitated or just knocked off their quote unquote normal feel to the world if things around them are too loud, too bright, too noisy. If the smell is overwhelming, if the taste is overwhelming, if the texture is overwhelming or underwhelming, this can become a symptom of somebody with this diagnosis where seeking sensory input, as in getting more sensory stuff, which you'll see somebody playing with a fidget toy, looking at certain types of lights, and I'll show you examples of this in Philadelphia shortly, or needing to go to a space that's completely quiet, that removes all the stimulation, because once a person with autism gets over or understimulated, usually it's overstimulated, they might start having symptoms of other issues more intensified. So you might have somebody having more repetitive movement. So I'll give you an example. I'm not sure how many of you were in our last talk, but I may have said this last week, but nonetheless, it's a good story. I had been working as a one-to-one aide in a public school at the very beginning of my career with a 4-year-old who had autism spectrum disorder, and at the time autism. And he was did not verbalize any needs, wants, desires. I never heard him utter a word in the entirety of the year. But he certainly had the understanding of or receptive language. He understood what was being said, and this was a tough place for this young boy to be in a learning environment, because and I specifically said it was a public school because public schools, and this goes back 20 years, had the idea that if we're going to have people with autism in the regular school with everybody else, this is at the beginning of No Child Left Behind and all of that, we need it to be welcoming, and it needs to be just like all the other classrooms, which is really, in hindsight, not a good idea. So the room was colorful. It had bright, all the letter people, Mrs. A, Mr. Buttons for Mr. B, if you guys remember that stuff. Posters, all sorts of different, really bright, colorful things. And very often the young boy I was working with would stop and stare at something, and he would do this. And I could not get him to come back. And that's called stimming. And that, again, comes back to this repetitive motor movement. And he would be in the middle of learning a task, learning some type of educational program, and he would just stop. It would interrupt it. And we knew this was an issue, and there was literally nothing we could do about it because the policies were not accurate and they were based off of poor information. Because at the time we didn't really have great updated research. So that was a problem for this boy, and it continued to be an issue and a distraction for him the entire year, unfortunately. Some kids need a public type of classroom. Some kids don't need a public type of classroom. You've heard me say possibly in last week, if you've met one person with autism, you've met one person with autism. Everybody's needs are different. which is why a lot of this diagnostic information is all over the place and takes things from different areas. So if it's overwhelming the amount of information and we're not even through B yet, then you're probably understanding the complexity of autism and why a lot of the symbols are puzzle pieces. That's what we're trying to figure out. That's at least the original idea behind this symbol. Since then, it's taken on a different connotation, but nonetheless, that's where things were figured from the beginning. So that sensory input, that's what's important. Now, for you guys, for MRC volunteers, and again, if you didn't hear me last week, I'm going to try to stop saying that, I promise. I am also a volunteer. I'm a volunteer in Jersey where I live at Monmouth County. I'm on the leadership committee. So I do these with the idea of I could be doing this myself. So why is that important? Great question. Sensory input in a setting like I always forget the word, a shelter. Thank you. A shelter, you have no control over the environment. So it's important for you to come back to learn, to listening to stuff like this so that you might be able to help a person. I didn't even plan this. I'm just looking around my desk at things. Even something as simple as a bottle of, you can barely see it, as a plastic bottle of water, it can crinkle. It's something that has texture to it. Like looking around the room, you never know, there could be something that could be stimulating. You don't know until you ask. You don't know until it's been identified. Or the sound that somebody next to them could be doing could be agitating. So these are small things to look out for when you're working, in this situation, or honestly, any situation in life. You could be in a waiting room with a person, and it's very clear to that as well. Symptoms must be present in the early developmental period. Now, you may have heard recently that there is an uptick in autism, and that's going to be covered in a little bit. That's the CDC study. There's anecdotal evidence because we aren't very good at collecting information on adults when it comes to autism, but there is anecdotal evidence that there's an uptick in adults getting this diagnosis as well. And this is where it gets into a little bit of a gray area because the symptoms are supposed to be present in the early developmental period. But if we go back to the original definition, everything is supposed to be current or by history. And in order to get this diagnosis as a child, it is very rigorous. Previously you could come and see somebody, they would talk to you, maybe do a couple of screening tools, something like that, interview caregivers, parents, whomever. Then they could render a diagnosis. Now, it's heavily used standardized testing. The standardized testing that we talked about recently, is applicable to here. So not necessarily an IQ test, because again, something that's really important, and I'm glad I just thought of that as I'm talking to you. There's nothing in this diagnosis about intellect. There's nothing in this diagnosis about cognition. So remember that aspect. Just because somebody has this diagnosis, there is not a guarantee that there will be an intellectual disability. As I've been saying, they are completely separate disorders. Is there some correlation there? Sure. But it's not as much as you may have thought in the past. So coming back to where I started, symptoms must be present in the early developmental period. So that early developmental period, again, think of this almost like our Constitution. Think of it like the Bible. Things are open for interpretation, which is why we're seeing this uptick possibly alongside a lot of awareness campaigns that have been going on the last few years with this uptick in diagnosis of somebody as an adult. I personally, professionally think this is referring to the years up to and including maybe the age of 6 or 7. Bulk of diagnoses are between the age of 2 and 5 because we are leaving early intervention and we're heading into public school settings. So in order to qualify for early intervention, you go through a process of appraisal, assessment, and if you qualify for specific reasons, you get those services age 0 through up until the 3rd birthday. So the day of your 3rd birthday, you're done. Then, unless you have gone through that process and get an individualized education plan, which you have to go through your school system for, that can now get you schooling and services ages 3 through and up to 21, which is when then you go into a different adult system. A lot of issues around those gaps. That's a whole other conversation, but just wanted to let you know that that's where all this generally comes from. Symptoms must cause significant impairment in social, I used that wording earlier, and then not due to another diagnosis, or I also want to point out that includes medical diagnoses as well. So genetic um, there are some genetic disorders out there that do mimic and come close to the same diagnoses. So sometimes you'll see somebody with multiple diagnoses. It's essentially, sometimes it's the same thing, sometimes it's not. It really comes down to how was the diagnosis made? Where was it done? Like, was it done at a CHOP, at a children's specialized hospital that does this? Or was it done in an outpatient office, you know, a PhD versus an MD when we're talking about genetics? Like, not all assessments are created equal, I guess is a good thing to say. Moving forward from that, we're going to start moving away from the heavy stuff. Just so you're aware, the spectrum itself ranges from the lowest level needs being level 1, and then 2 be needing more, and then 3 being people that need substantial support. There are specifiers in the DSM that help clinicians pinpoint this for your purposes as a volunteer. The level means nothing. It's very unlikely somebody is going to be coming there and saying or having a badge or something like that where they're identifying and self-identifying and telling you what their level is. I don't think you need a medical degree or a degree at all to figure out, generally speaking, where we're talking, but I'll throw it out there. Requiring some support. So this is a person that made the criteria for whatever reason. And they give us some examples. Probably difficulty in initiating social interactions, organization and planning problems can hamper independence. This is kind of where my buddy is at that I mentioned earlier. You know, you can tell that he's got some social things there. He had a rough upbringing because he didn't get that diagnosis for a very long time. So people just kind of considered him to be the oddball or the weird kid, which isn't obviously something that you want to repeat, which is why we have this spectrum so that folks that do have some needs can get them. Middle level is middle level. We might be seeing some issues beyond just the specialized interests and the emotional reciprocity issues. We might see some substantial issues with our ability to verbalize communication, things of that nature. And then level 3 is like they're unable to express their needs, their wants, their desires. They may not be verbal at all. This is somebody that might need help with their activities of daily living. So again, as an MRC volunteer, I don't know where things go. Hopefully somebody's showing up with a caregiver, but these are folks, just so that may have needs regarding their daily living needs. So showering, toileting, dental, all of it. Sometimes we see positive correlation with people with autism and physical disabilities as well. There's some correlation there with muscles not being as like there's muscle tone issues. So that could create some ambulation or walking issues. Sometimes we see fine and gross motor movement issues. So fine motor movement are the small muscles that you have in your body for certain things. So being able to write, handwriting, things of that nature, being able to pick up a spoon to feed yourself, like things like that, being able to open up a bar of soap, to gross motor movement, which talks about large muscle groups. So being able to physically walk, being able to run, to be able to jump, all those things that come with being a child or an adult actively. Okay. I like this slide because it just got affirmed by the recent information. So I'll just give you, again, some of these slides are now dated because so we'll just get to that part. A very large study that has been underway for a number of years just got updated last week. It's a CDC, Centers for Disease Prevention and sorry, so I'm just trying to get in touch with it. So the CDC, nonetheless, had put out this updated surveillance. So surveillance it's a public health thing. So Tori could tell you about that another time, where we're monitoring to see how many people have a certain disorder or diagnosis that are out there. And an entire cohort, a group of 8-year-olds and 4-year-olds in I want to say 8 different states. You're talking about thousands of children. Their charts are medically reviewed biannually, so every 2 years, and they're following the cohorts as they move through the public school system or whatever school system they happen to be. Again, it's across 8 states, many school districts. And what they found recently was that the prevalence has gone up. It was previously, as it says here, the number of diagnoses increased 5-fold between 2000 and 2016. I believe the previous number was 1 in 36. The number is now 1 in 31. And this is referring to just children. So what I talked about earlier with the increase in diagnoses of autism in adults, that's not part of this. So, and I know a lot of folks immediately think, and rightfully so, would go to that. But if you go and look at the research itself and read it, and it's honestly, the discussion section is not that technical. It just talks about how things are changed and how they got the numbers that they got. It provides a lot of additional data. Besides the fact, what it doesn't tell us is why is this happening. That's where recent stuff in the news comes into play about whether or not there is an environmental, a genetic, or whatever cause this is. And there is a new call for research in finding what the origin of autism is. That's all I'm going to say about it. The other good stuff about this prevalence coming out, obviously it's bad news. We don't want to see that number go up. These are folks that can have some substantial needs. Not everybody does. That's an important thing to remember. That's why we have these 3 different levels. I think certain things that were being discussed, we're talking about the highest level needs that are out there. But it's a spectrum. So there are other aspects that are out there that are not being represented in those statements. So I think that's just important to point out in April of 2025, as we're just starting to see where things are going. I think it points out that something that we do not know. We don't know where it comes from. It is the first, or one of the first times, I should say, that the government is looking at some very specific funding and research and stuff. And hopefully, at the end of all of this, we learn something. Whether it's still don't know what the cause is or whatever it is. Hopefully, we learn something. And because of the focus on autism, for whatever reason, there is additional funding and assistance for everybody on the spectrum and their caregivers. Moving forward from that, the CDC, the actual research that was done and published, or you literally just go into Google, write CDC ASD 2025, it'll pop up and you can click on the actual article. It's huge. But if you don't like statistics, you can scroll all the way down to the discussion, and I would read the methods. It really gives you a good idea as to how and where this all comes from. And when you hear these statistics out in the news everywhere, that's the literal source document that it's coming from. One of the great things that it shows, aside from the demographics, so we know who is getting the diagnosis, at what point, how, we're learning how the person's getting the diagnosis, what testing is being done. So this is a surveillance project, is major research. My wife actually used to do it for Zika virus, and they would do these chart reviews, they call them, and they would literally page by page going through and looking for things, and it's pretty incredibly detailed research. So it's as good as you'll get for this subject. And it's the most major one that's out there. But again, I keep coming back to one of the most important things is that, and I alluded to it earlier, upwards of 75% of people think those with ASD are assumed to have an intellectual developmental disability. And this was based on previous anecdotal research. The research that I keep talking about repetitively is the newest, and it's non-anecdotal. It's actually the case surveillance, which is way better than anecdotal research. Since it's been updated and we've been looking at, they're looking through all these charts so they can extract a ton of data, they're learning that 2/3 of people do not have IDD. So the majority of people with an autism diagnosis do not have a developmental disability. So that means that 2/3 of those people with this diagnosis have at least an average IQ, at least. A lot of those folks, many of those folks, are actually on the high end or have specific areas of intellect that they are very, very much off the charts when it comes to how advanced they might actually be. If you actually look at, if you're into any of this stuff, you can Google around IQ testing for people with autism. There's almost like a profile. An IQ comes from, depending on the test, there's 5 or 6 different subtests. Kind of like if you took standardized testing in school, you had a total battery of how you did in English, and it would break it down to verbal and nonverbal and all these different things. And that's how it's done in an IQ test. And you'll see where certain areas are extremely low and then other areas are extremely high, giving a full scale IQ as an average. But there's a specific profile where certain things are very high and certain things are not. And it's very indicative of this cluster of symptoms. So it's interesting to see, and that's important for you guys to remember that, just because somebody is potentially sitting there nonverbal, even stimming or any of those things, their IQ might be significantly higher than you think it is, and you still can potentially communicate with that person, just not using spoken word. There's a lot of other ways to communicate with people, right? We can use text, we can try to text, we can use emojis, we can try to do pictures. iPad is a great method of communication. Some folks have communication devices built into those iPads where they can tell you what they want based on pictures, or it'll actually speak to you depending on the level of what they have and what their ability is. But those are things that are very important. I've actually seen in the past people using that communication device as a reward system. Don't do that. That's like taking somebody's tongue and removing it temporarily because you didn't like how they acted. A lot of times, if somebody is having some agitation or something like that, and you're assuming a diagnosis, a lot of times it's related to their inability to communicate their wants, and it's frustration. It's not any of those other things, which I'll get to shortly. Talked about this, and I was right. It's 1 in 36. So again, this chart is two years behind schedule. So everybody needs to update all of their graphics and all of that stuff, again, because the stuff just came out. And just to say, a jump of 1 in 5 going up, 1 in 36 to 1 in 31 in a 2-year period, that's like a 16% jump. That's a very high escalation, making this line, that slope, being even more sharp, so to speak. So that incline there is concerning, because we know that even if we know that everybody's on the spectrum, people have different level of needs, but the prevalence, or the population, is growing, which means there's going to be a higher level of need. And we're already way behind in our waiting lists, our ability to treat, our ability to train medical professionals. Like, you guys are volunteers. Some of you, I think, are medical professionals, and it's great that you're here, but we don't do this on a broad scale. There are no requirements in medical school to become a medical doctor or to become an RN, LPC. I'm a licensed professional counselor. I took 0 courses on developmental disabilities in my graduate schooling because there were no courses offered. A lot of times that's the same for nurses, that's the same for doctors. Sometimes it's not, but the majority is, and it's getting better as far as where it's at, but we're hovering in like the 50% range. So even if we started teaching everybody everything tomorrow, it would take years to catch up, because not everybody's going through medical or graduate school or nursing school. Those folks are already out there. So we're trying to get this out into the field, but some people just don't want to do treatment in this area, and I'll explain why at another time when we get into like the healthcare system and its effect on things. But it was important for me to get to this. Comorbid behavioral health diagnoses. People with autism, the diagnosis sometimes often can get a bad rap, or a bad reputation, because of what I mentioned earlier, the agitation, aggression, because of an inability to communicate. And sometimes that can get broader into the diagnosis world of adding on new diagnoses. And what happens sometimes, this is what we would consider to be accurate numbers, but sometimes people get brought into emergency rooms and all that other stuff because they are showing aggression or agitation. And the reality is they are having a dental issue, or they have a horrible headache, but they can't communicate that. And so they don't know what else to do and they're getting frustrated. If you've ever been so frustrated yourself and you can't get it out, you just think about your verbal language, your nonverbal language. If you weren't able to speak what's bothering you, like think about that the next time you see somebody that isn't verbalizing things. You can tell just by looking at a person very often what's going on. But I also wanted it to be very clear that it is possible to have an autism diagnosis, which is a type of developmental disability, in addition to another diagnosis. Now, I will say taking ADHD, possibly even anxiety disorder and OCD with a grain of salt. Why? Because some of the symptoms are similar. They're not the same, but there is some crossover there. So like I said earlier, sometimes a diagnosis is rendered and it may not be accurate. So sometimes there's a concept in developmental disabilities called diagnostic overshadowing. And you're going to hear me say that more than once, I promise. But diagnostic overshadowing is when we apply a diagnosis to somebody based on the wrong symptomology. I'll give you a very, very quick example, which I've said before, but you're getting a very toned down version of it. We had a gentleman with diabetes and schizoaffective disorder, and at the time it was called Asperger's. By today's definition, it would be autism spectrum disorder level 1. And he came in one day to triage. Nurses saw him. It was a very busy day. He was acting very psychotic. He has a psychotic disorder by history. They saw it. They saw he had been the last 5 times he was at that hospital. He came to see psych. We evaluated him, and within 5 minutes, we realized there was something beyond his normal psychosis. Long story short, it was his diabetes. His blood sugar was above 400, and he was having he was having delirium because of his blood sugar. It had nothing to do with his history of psychosis. That is called diagnostic overshadowing. The nurse that saw him saw his history. Anybody could have made this mistake, but the consequence could have been that we could have literally killed him. The psych area has no way of knowing, has no way of checking blood sugar, has no way of saving anybody's life because there's nothing available in the psych area that anybody can hurt themselves or anybody else with. They did not check his blood sugar in the triage. That was where the issue, that's where it happened. He ended up going to the ICU. He lived, everything was fine. When he became more aware and more oriented, he looked at me, called me by my first name because we had an ongoing, professional relationship. He had been to the hospital, like I said, several times in the past. But nonetheless, he could have had some other issues go on. So I say that for you to remember other diagnoses can go on. It is possible for somebody to have a diagnosis of autism and schizophrenia. Now, it's very low if you look at the percentages and the statistics and you think about that, but it is possible. And there's a whole genre that's dedicated to just this dual diagnosis, which is something that I've spent a lot of time working in. But nonetheless, for you guys, just being able to understand, again, if this is somebody that's in your shelter or at your flu clinic or whatever, just you're there to support them. You're not there to diagnose them, but you're there to keep them calm, make them feel safe, keep them focused, just focusing on, the future and making sure things are good, checking on them to make sure that their impulses, their sensory inputs, all of that is doing okay. You don't have to get into the trauma that they just went through, which is why they're sitting in front of you at a shelter. So keeping in mind, if they are at a shelter or some type of deployment, they've already had some issues that day. Some treatments, I'm going to talk about the most accepted treatment that's out there, which is called applied behavioral analysis. You might have heard it. It's been around for some time now. It is the gold standard from what folks say. There is a group of people out there that does not like ABA. They don't feel that it is humanistic because of how it's done. A lot of it is based on rewarding somebody. So for example, the young man I mentioned earlier, who I worked with at this public school, when he would listen to a command, and literally the basic command that we were trying to get him to do, and before I tell you what it was, this is to get him to improve his receptive communication skills. And I had a big binder, and we would fill in every time I said it, and he did it or didn't do it. Okay, part of this discrete trial stuff. And I would say his name, say, can you sit down? And if he sat down, he was given an M&M. Now, there are people that feel this is, like I said, dehumanizing. There are people that think this is the best possible thing because it helps children and adults with autism improve their behaviors that are out there. The opposing consensus says that ABA is taking the very center of what that person is, telling them that who they are is wrong, and teaching them how to be like everybody else in society. Again, I'm here to bring you the information. It's up for your interpretation, but the reason why ABA is considered the gold standard, A, it's covered by most insurances because there is research that says there are positive outcomes with it. There are no other specific, autism specific, I should say, research that's out there that says X is a good treatment because Y happens. So this is why it's very well accepted in a lot of places. Major hospitals, outpatient clinics do this. It's very time consuming. You're talking 20 to 40 hours a week with a specific ABA therapist. So like I said, that it's intense, and it's intense beyond just the patient and the provider. If there are caregivers involved, they need to be educated and trained on how to continue the modeling and the behaviors when that person's no longer there or goes home for the day. So it's very intensive, but there are some gains there that people find to be useful. There's a lot of pharmacology out there that's utilized. I'll just hear this. The FDA has not approved, to my knowledge, a medication that is specifically there to treat autism spectrum disorder. However, there are a lot of prescribers that do use different types of medications for different purposes. A lot might have to do with impulse control. A lot might have to do with along the lines of ADHD. And sometimes pharmacology is used for agitation, things like that. Like I said, things don't happen in a bubble. You can have more than one diagnosis or behaviors that are similar, but not necessarily equate to a diagnosis. So there are different things that are out there. One of the important things for you guys to understand is there's a hierarchy of need out there for all of us, right? When you wake up in the morning, hopefully one of the first things that you're not worrying about is your food, your safety, your water, things like that. You know, hopefully you're figuring out, all right, today I have to go to work, or I'm volunteering, or whatever it is you do. When you're working with somebody with autism spectrum disorder, some of the most important things to those folks might be the physical structure and schedules that occur in their lives. And that goes back to the original diagnostic criteria I was talking about earlier, that some people with autism are very restrictive in their ability to stay on or off task, and that comes along with schedules. So somebody who is used to living in the same group home and going to the same day program every day, or going to work every day and having the same, commute home, and there's a massive hurricane or a flood or a public health emergency of any kind, and now they're not allowed back those places. They're in front of you. The most important things to those folks has been disrupted. So you may see people that are agitated or irritated that need more support than normal. It doesn't necessarily mean that because you're seeing somebody that's angry, they have something here. If I am being removed from my home where I live every day with my family, whether that's my family or the people I live with in a group home setting, whatever it is, it's what they're used to. It's what their norm is. And again, that ranges just like the spectrum does. But I know I would be very disoriented, disrupted, what have you, if my day-to-day was disrupted and now I'm potentially sleeping on a cot with 100 other people in the same room. Go back to that sensory thing. If you ever been sitting next to somebody that's sleeping in the public and, they're snoring or they're making noises, or, even if they're awake, they're sitting there, they're biting their nails, they're doing something that's annoying you, and you kind of tune into it. Imagine that on a much broader scale all the time. We did look at this slide specifically last week. I wanted to include it again because we're talking about hidden disabilities. I know we did a huge chunk of autism, and I will whatever we don't cover with hidden disabilities, I will get into. But again, when you're thinking about what a hidden disability is, and there's no technical response to this, it is literally a disability that you can't see. By definition, autism is a hidden disability. Um, Having said that, so is traumatic brain injury. So is depression, anxiety, any mental health disorder for the most part, pain disorders, central nervous system issues that aren't grossly impairing people's ability or their physical look. All of those are hidden disabilities that require assistance. So it's an opportunity where if you see somebody struggling, you can simply ask them, is there anything that you can do to help them feel more supported, more at home, things of that nature. Going into the broader definition of neurodiversity, um, you may have been hearing this term over the last 2 to 3 years. It's become a very popular word that's out there these days, and it's non-medical. It does not come from any diagnosis. It includes people that have certain diagnoses, which you can see here on the right. But the diagnosis itself isn't medical. It's a term that classifies people as simply saying their brain functions differently than the majority of people that are out there. The statistics that are out there say about 17 to 20% of people on the planet are neurodiverse. So it includes people with dyscalculia, dyslexia, lots of different learning disabilities, mental illness. This is acquired neurodiversity, which would be a traumatic brain injury, or a tumor that changes behaviors, any of those things. All of these things are included under that umbrella, and it keeps getting bigger and larger. It used to be mental health was specifically only, I want to say it was only like acute anxiety disorders, and now it's gravitating towards everything. And again, it's out there for people to feel like they can identify alongside someone. So being neurodiverse is something that people are identifying with. It's not something that a clinician is saying you are neurodiverse. They might use that wording, but there is no you have a diagnosis of neurodiversity. I could guarantee you an insurance company like mine, yeah, that's not a thing to us. But as an employer, we are paying attention to neurodiversity, and as a company that is in charge of caring for people that are out there, this is stuff that we're paying very close attention to, because our members do have these things and do need maybe some different ways of looking at things. Want to come back to this real quick. Just showing you the progress of those symbols over time and how things change. As always, these will be made available to you if you want to come back and really look through it. But that puzzle piece is back from 1963. The infinity symbol is a more recent thing. And then we have this embracing neurodiversity where we're actually now saying we accept it for what it is a whole other thing. And that's the slide I wanted to really show you. This on the right-hand side here is an opposing graphic. The blue side shows you the older, more orthodox approach to autism in that it follows a medical model. So we look at people and we try to treat what we can improve on. The opposite side is more accepting. You are who you are. We're not going to change you. We're going to collaborate. We're going to focus on your strengths. Now, again, depending on where you fall on the spectrum of things, this philosophy can be helpful or it could be hurtful, but I wanted you to see both sides. And there's specific wording here that you'll see obviously is different. Epidemic, tragedy, functioning labels. Like, again, I even said it, accidentally, someone that's high functioning or verbal, that's a way that we used to refer to folks because it's how things are classified in the DSM to some degree. And it's a quick way of conveying messaging and information fast. The issue on the other side is that we've got people that say, I am prideful of them, not a problem. It's the opposing side, centering autistic voices, including folks. And this is something that, like I said, my company's doing right now. We're designing specific space for folks that consider themselves neurodiverse so that if they're overwhelmed in the workplace, they have a place that they can like reset for a couple of minutes. So blue represents pathology that needs fixing. Red is representing acceptance. And as you can see, just like the ABA and almost like a lot of other things in this world, we have opposing sides. I am going to, I think, wrap it up at this point. I wanted to show you, and I'll show you this stuff and then I'll stop. There are spaces out there in public venues that I think are important for you guys to see and to know about, because you may have an opportunity, especially if you know there's going to be a shelter situation for any reason. I know we don't always get notifications that a disaster is coming, but prevention is part of this, right? My goal is to see shelters out there with sensory friendly spaces so that when somebody is in a tough situation where they are required to be in a shelter that is so different from everything and it's going to throw their baseline off and make them potentially upset about stuff, we can try to make things a little bit more comfortable. So, what does that look like in the world? This room right here has an aquarium, has some lighting. This is a sensory board where you can physically feel things in it. That tactile stimulation is actually research proven. There's parts in your brain, especially when using, if you have an autism diagnosis or a neurodiverse, there's parts of your brain that will specifically get calmed down, or it'll actually slow down the central nervous system when stimulated. So when you're getting on an airplane at Philly Airport, we know that's not the most enjoyable process going through TSA or anything like that, or at a bus station, they're starting to add these things as well, so that there is a space for people like this to go and relax before they have to get on their flights. And here we see an airline attendant with somebody with autism, interacting with them, giving them some sensory stuff. I mean, a lot of airlines out there have specific programs, and Disney, Universal, Six Flags, they have done a lot of trainings as well that teach people how to better interact with folks. There's a great one out there called Magic with Thomas. If you are a YouTuber or anything like that, you want to check it out. It shows a gentleman who's probably a level 3 guy walking through Disney and all the other theme parks in Florida, and how the staff interact with him. And I think it's amazing the job that they do. This I had to get to before the end of the night. This is your Eagles sensory room. Eagles have a great autism program. And if you look closely, there's a lot of, excuse me, I'm losing my voice as we're wrapping up here. There's a lot of different textures, lights. These are bubblers that make different sounds. And this is in the link where a person can physically go there. You don't need any documentation. And you can go there and be in a space like this if you're feeling overwhelmed, because, you know, I know Philly doesn't have the craziest reputation for their fans, but sometimes things can get a little overwhelming. So it's great that this is out there. They were one of the first people to do this, so good for them. It's being copied all over the place, and it's really a great thing to see. One last thing I want to let you guys know about, especially the public health folks, special needs registries. There's one out there in a lot of different places. There's 2 different types. One lets the government know if you need assistance in evacuating. There isn't one of these in every area, so you need to check where you live and where you work for this. But basically, it lets somebody know if somebody has a physical disability and they can't physically get out or evacuate. It lets the first responders know that somebody needs to be evacuated. Great system. Unfortunately, when it doesn't work the way it's supposed to, people wait and nobody ever comes. And obviously that doesn't have a good outcome. So this is something, again, this is part of our initiative trying to raise awareness about this stuff. And we're looking to do that. The other side of the special needs registry is to let first responders know there's an emergency in your home, work, wherever you're calling from, and there's a person there with special needs. There was a recent shooting in Iowa. There was a 17-year-old with a gun, I think got his hands on a gun, doesn't matter how. The fact is that the police saw what was going on, and unfortunately it ended in a police involved shooting, killing the I believe killing the 17-year-old with autism. If that gentleman was on a special needs registry, it's possible the police would have been given that information. The information comes from the caregiver or the person themselves. And if you've ever seen in the movies or a show, or you know a police officer, or you are one yourself, they have a computerized system in their police cruisers or wherever they're coming from that would put out that specific information. In this situation, lights and sirens might agitate this person and escalate them. Any piece of additional information that a police officer can get, or a firefighter or an EMT could get before going to a residence, could literally save that life. So this is important information for everybody to know about. One last thing, and then I'll pause, I'll stop, are these new cards that New Jersey is doing. They're trying to push this everywhere. It's another thing, another way of identifying yourself or somebody with you. It sits literally alongside your driver's license so that if you're pulled over at nighttime and you have autism or something like it, you'll see there's some other things on here that talks about communication disorders, right? Because again, you could have an average IQ or higher. You can have a diagnosis of autism. You may have no physical issues that would preclude you from working and having a driver's license. But if you get pulled over at 11 o'clock at night on your way home from work and you have that spotlight in your rearview mirror, and now you're getting, we all get nervous when we get pulled over, right? But if you have a diagnosis that makes it even more of an issue for you, where you might be stimming or you might be looking around very nervously, a cop doesn't know that you have a diagnosis and they don't have abilities of knowing that, and they see you fidgeting around. It's conveying a completely different message to them than the one that we want to put out there. So police are being trained on this alongside everybody else that needs it. I think it's a great thing, and I'm gonna wrap it up and apologize for going over by a couple of minutes, but I will stick around if anybody has any questions or just wants to say anything. But thank you for hanging in there with me.
Thank you so much, Jason. I'm looking at the chat and there hasn't been any questions yet. So I think you answered everyone's questions. But if anybody does have any lingering thoughts, please feel free to reach out. Happy to pass longer questions to Jason, or you can, directly respond to him himself. But yeah, so again, thank you, Jason, for the second part to our series. We're really excited to continue this. If you enjoyed this training, which I certainly did, there'll be several others that, are included in this series. Typically, again, Mondays between 6 and 7, again, with Jason here. So we will be sending out reminders. Please join us, invite your friends, tell others. We love the engagement and to have other people have access to this information, which is so, important in today's time. So yeah, thank you again for everybody who, spent your Monday evening with us. We'll hang around if anybody has any questions or lingering thoughts. And then other than that, enjoy the rest of your evening. And once again, thank you, Jason.
Yeah, thank you guys. Okay.
Okay, literally not seeing anything. So I think it's
I think we're good.
say that we're good.
Yep.
Thank
I'll
you
see
so
you in
much.
May. Take care,
See you.
everybody.
Thank you so
I'll talk
much.
to you in
Goodbye.
May. Bye-bye.